So today's session is the family checkup, a model for prevention and intervention with families. And we have this presenter with us today. We're so excited to bring to you Dr. Lisa Ryder. I have a few notes to say about Dr. Ryder. If we might have a presenter slide for you, Dr. Ryder. If so, I would love to read it off. There we go. So this is just a little bit, we're giving you the highlights here, but there is so much we could say about Dr. Ryder. So Lisa Ryder is the clinical director for Northwest Prevention Science, the purveyor organization for the family checkup model. She has a PhD in clinical psychology and more than 25 years of experience working in the evidence-based practice field. Dr. Ryder worked at Duke University Medical Center in North Carolina, where she was involved in research projects that led to the development of the coping power model. She also conducted family therapy, supervised trainees, and supervised an MST, multi-systemic therapy team. She then moved to MST services, where she served in multiple roles, first as a trainer and then as a clinical director for 15 years. And with that, Dr. Ryder, we want to say welcome. We're so excited to have you, and I will pass it off to you.
Thank you very much. Just a quick check. Everyone can hear me okay? Yes?
Yes.
Yes? Yes. Okay, great. Great. So as Jess just said, Northwest Prevention Science is the purveyor organization for the family checkup model. And what we'll be doing today, the goals are to help you all understand what is this model, what's involved with it, what's the content look like, what's the process look like. And the main objective here is to help you all with your decision making. To consider what might it look like to implement this model with the families you serve in your community, and to decide whether this is a model, this is one of the EBPs that you either would like to include in your county plan if you're one of those people who can choose what goes in the plan, or perhaps to request it if you're not one of those people. And I was just thinking about something as I was preparing for this presentation, and thinking about the full circle I've come. I hadn't made the connection, but I actually started my career in California. Career might be a stretch. My first job after I graduated from college was with the Children's Bureau of Los Angeles. I always say if you're a psychologist who's going to work with kids, working in a group home setting is one of the best ways to start because it's a sink or swim kind of role. So I was a relief house parent for group homes across LA, the Valley, Santa Monica. Long time ago, but that was where I started there in California. And now I'm with this model, the family checkup, which here we're going to start with sort of the big picture. What's the model about? What does it do? It's a model that targets child problem behavior with a parenting focus. It's about family management and parenting practice. That's the lens, that's the focus. It's a brief model, family-centered, strengths-based, and very much tailored. It's a flexible model that not only allows, but it is central to the model that the work is tailored to the family and their particular needs, their strengths, their culture, their values. There are two major elements we'll talk about in a moment. And what those elements do is they take an empirically validated assessment process that is infused with the spirit of motivational interviewing to engage families through this assessment process and then bridge to other services. And we'll talk about some of what those other services look like. What we found with this approach is that there's a very high engagement rate with families and a foundation of more than 30 years of research support to show strong intervention effects for this model. And there are indicators that this is the most cost-effective of the well-supported EBPs across the widest age group. And so that target population includes the age group of 2 to 17, very broad. It is designed for children who are living with their caregiver, with a dedicated caregiver. Could be kin, could be a permanent or long-term foster care placement. But as a parenting model, the child needs to be living with the caregiver. And it might be multiple caregivers depending on the family. If there are multiple caregivers involved, they all could participate in the intervention. The other point of flexibility of the model is it can really hit the full range of primary prevention all the way down to tertiary, to be used with families in a purely primary preventive way. For example, it can be used like an annual medical exam, physical exam. So it's the family checkup as opposed to a medical checkup. Or it can be used as part of a larger set of interventions with families who have more significant needs. It also can be used in rural and urban settings, and we'll talk in a couple minutes about the research which has examined the effectiveness of the model in both rural and urban settings. Bottom line is that this is a model that can be used for a very broad range of needs, a very broad range of families across your community. Here is the core theory of change. There are these two components to the model. One component is this FCU, the family checkup, the assessment piece. The other component is called everyday parenting, and that's a parenting curriculum. These two components influence and are designed to intervene around parenting, family relationships, and family processes. And it is through those that we see the positive child outcomes that have been found in the research. And here's just a brief summary of the evaluations that have been completed with several randomized clinical trials. They've been completed with culturally and socioeconomically diverse families, as well as internationally across many different service settings, and as I said before, across both urban and rural communities. And this is another visual of the model that shows on the left side the assessment piece with 3 sessions with the family. On the right side, we see the follow-up services. This is what I was referencing before, that this empirically validated assessment. Then at the end, there is this bridging over to follow-up services with the family. And you'll see 2 boxes there. The first box of type of follow-up service is the everyday parenting family curriculum, which many of the families who participate in the checkup model choose to include some parenting sessions as part of their follow-up. They might also set goals related to what's in the second box here, community resources and supports, which means that parenting skills development wouldn't necessarily be the only kind of follow-up service that would match the goals and the needs identified through the assessment process. So this box of follow-up services is quite broad. The other point I want to make here, and the choice of follow-up services are very parent-driven. So some families, some caregivers might not choose to use everyday parenting sessions. It's very common, as I said before, but it's not required and it's not guaranteed. The last thing I want to point out in this depiction of the total model is the fact that it is all implemented with this context of the spirit of motivational interviewing. So MI is woven throughout the entire process of the model. Now to get practical. practically what happens with the sessions and the service setting. There are typically 3 sessions in the first component, the family checkup component. As we just saw schematically in the previous slide, those 3 sessions include an initial interview, an assessment session, and a feedback session. For families that do move into the follow-up service of everyday parenting, the number of sessions there is varied. Again, because it's a tailored process driven by the parent's goals and needs identified in the assessment. There is a curriculum from which sessions are chosen, but it's more of a menu than a standard, all sessions are delivered. In terms of delivery time, what does it look like? Usually the family checkup process of time with families is about 3 to 4 hours total, usually across about a month. Everyday parenting, what we have found over time is the average is 3 to 4 hours of everyday parenting sessions. There is some indirect service delivery time. For the family checkup component, between the assessment and feedback, the practitioner does some work to pull together all the assessment information, develop conceptualization, and prepare for the discussion and the goal setting with the family. That takes an hour to an hour and a half. The prep for the everyday parenting sessions, once the practitioner knows the process and is familiar, is just a 10 to 20 minute prep because they have a manual to draw from with the materials, the handouts, etc., all prepared and ready to use with families. In terms of service settings, the model is designed to be delivered across a range of community settings, both rural and urban, as I said. And at the bottom there, you see that a virtual video platform is a way that these sessions can be delivered. It's an option. And that is helpful when families are more geographically remote, when someone's sick, or family just can't fit a session into their schedules. And the sessions could happen home, school, community, or in a clinic setting. So it's, again, it's a flexible model. Now to move from practical back to more theoretical and describe the model and what is entailed in the model. The key principles, a few of these I've already referenced, so I'll go through them relatively quickly. The first is that it's assessment driven and tailored. As I referenced, we start with that assessment process, and that drives everything else in the intervention. And the tailoring to the family happens across all elements of their context, the social context, cultural, economic context, and it's tailored to the readiness of the family, which gets us back to this motivational element, that motivational enhancement strategies are woven in throughout the entire process. And what we know, as I'm sure many of you know, I know MI is being used pretty extensively across California. The use of MI strategies really helps to promote a good working alliance and engagement. And MI, just like the FCU model, is very much strength-based and approaches the caregiver as the expert with a strongly collaborative process. And the goal throughout the process, through the assessment, through parenting sessions, is to empower the caregiver in their role as a leader within the family. And hand in hand with that is it's the caregiver who leads the change process. The last point here is about the health maintenance model, where the FCU model, the assessment especially, could be done annually as like a medical annual exam, as I referenced before. Some more of the conceptual elements to describe about the model is that it's culturally responsive. Following from all those principles I just described, the focus of the model is very much on relationship and connection between the practitioner and the caregivers, with this focus on empowerment of the caregiver, respect for the autonomy of the caregiver, and really working hard to achieve this equal power balance and collaborative process where the practitioner doesn't come in and say, here's what I think you should do, but rather engages in this very deeply, genuinely collaborative process of setting the goals together, both at the big picture and then session by session. Other elements that drive the cultural responsivity of the model are looking at contextual and cultural factors at that conceptualization and assessment stage, as well as throughout all of the interventions. Practitioners are trained to approach work with families with cultural humility. And the evidence indicates that intervention effects are consistent across white, Black, and Latino families. Staying at this conceptual level, the model is also trauma informed. And with this focus on prevention that is so much a priority in the state of California and so many places across the country, the benefits of a parenting approach, a lens really focused on parenting and strengthening positive parenting. We know how important positive parenting is to the prevention of child abuse and neglect. That kind of positive parenting approach also protects against the various risks that may be in the family's context and interfere with the caregiver's capacity to be effective in their parenting. And the last way that the model helps to prevent child trauma or child abuse and neglect is through disrupting patterns of conflict. Caregiver-child conflict, we know, can lead to child neglect and maltreatment. And that's one of the areas where if there's a need around parent-child conflict, that would be an area that we would work to address. In addition to that preventive impact, there is also a recognition of the impact of trauma that's woven into the model. So with that box we looked at a few minutes ago of follow-up services following the assessment, if there is evidence of trauma symptoms, either for the child, children, or caregivers, then in setting those goals and plans for follow-up services, the practitioner would be supporting the caregiver, encouraging the caregiver to look at follow-up services to address those trauma symptoms. And then throughout the work with the family, the approach is consistent with the principles of trauma-informed treatment, in that the practitioner is transparent, humble, collaborative, empowering, and strengths-focused, really looking to tap into, encourage, and facilitate the leveraging of the resilience of family members. And the last element of recognition of impact of trauma is that through the family checkup process, the part of the interventions and the assessment even itself are geared towards improving parent-child relationship quality, which we know when trauma has occurred for a child, that relationship quality is a protective factor for those kids with trauma histories. And then one more element of sort of putting the pieces together of the model design and what's built into the model design. And that's going back to MI, which, as we saw earlier, is the context. It's the background for the model. MI is woven in throughout. And this slide's designed to take those concepts and make them practical, to demonstrate how this process of partnering with the parent with compassion, acceptance, and empathy is then integrated and woven in to these two components. the family checkup component with the assessment. Here we have this list of how MI and the steps of the assessment component fit together. And so you'll see that in the points here, the focus on strengths, really seeking to deeply understand the parent's perspective, seeking to understand what's their readiness to change. And then this number 6, I think, is a really important one. The model and the assessment process, starting from the assessment process, is very intentionally designed to facilitate the parent's self-reflection and enhancing their own understanding of themselves and their families, to set the stage for them to set goals, to look at areas of improvement that are really driven from themselves, as opposed to an expert or clinician telling them what's going on with their families and what they should be doing differently. Practitioners are trained to use the ORS plus A, the typical MI strategies and skills. And then that final step in the family checkup assessment component is the goal development, which, as I've said, is really driven by the parent. And intentionally, those goals are designed to draw on the family's strengths, skills, and the resources already available to them. In the everyday parenting component, which would be part of the follow-up services, that partnership continues, the goals and steps being driven and selected by the caregivers continues, the empowerment focus continues, and the effort in an ongoing way to leverage strengths also continues. So back to this schematic that illustrates the model. I'm going to go through and talk about each of these pieces of the assessment briefly. The first part of the assessment is an initial interview, which is pretty similar to many intake sessions that are typical in various agencies. When we're working with agencies to start using the family checkup, we usually spend some time talking about if there's already a structured intake process that is pretty standard with families. We look at how do we weave together the agency established intake process with the elements of an initial interview. Often there's a fair amount of overlap, but then potentially some pieces that get added to reflect what happens in the FCU initial interview. This is a time for the practitioner to get to know the caregivers, to start that collaborative process and strengths focus and building of engagement. In the initial interview, practitioners attend to equally both positive functioning, family strengths, and preventing problems and identifying challenges and concerns, maintaining that strengths focus to cultivate the energy, positivity of the caregivers, as well as to cultivate hope for change and the sense of efficacy of the caregivers, that in fact they do have skills and resources they can draw on, and there is a good chance and a good likelihood of change. The second step in the assessment process is the assessment. And this assessment is an ecological assessment, looking at information across the child's behavior, parenting, and the family context, with multiple methods for the engagement process, the assessment process, looking across home and school context. Included in the assessment is attention to the context of the family. So for example, parent depression, marital conflict, those would be important variables that would be considered in the assessment process. The assessment is based in empirically validated questionnaires and videotaped observations. I'm going to talk about those in a little more detail in a minute. And then, of course, this assessment process informs the intervention targets and services. And the big picture of the assessment is really looking at understanding the child's full ecology and the various contexts in which the family is embedded, both the behavioral settings as well as relationship dynamics. The elements of this assessment are these two main components, component 1 of questionnaires and component 2 of family interaction tasks. And these are the two parent questionnaires that are completed, one on self and family and one on the child or the adolescent. And then if there is a child 11 to 17, there is an adolescent questionnaire that they can complete. And these are online questionnaires with automatic scoring that is immediately available to the practitioner as soon as the parent completes the questionnaires. This second component of these interaction tasks, family and child interaction tasks, is a relatively unique component in my experience compared to other assessment processes I've seen. These are structured interaction tasks that typically are videotaped, maybe audio taped if video isn't available, with set scripts. They're standard tasks, each one designed based on the developmental level of the child. So different tasks for 2 to 5, 6 to 10, 11 to 17. Scripted, structured, videotaped tasks that then are coded later by the practitioner. So I think we all know that self-report alone is a really important source of information, and observations are another important source of information to inform our assessments. So this two-part or two-component assessment is designed to tap into both types of information. And one point, just to go back to that parent questionnaire on child, this second piece here, there are also different questionnaires for the different age groups, tailored developmentally. Then the assessment information is pulled together by the clinician. So they prepare to have this last session of the assessment process, which we call the feedback session. And in the feedback session, the clinician takes the information from the initial interview and those two parts of the assessment to integrate all the information to share it with the family. This piece is, I think, another relatively unique element of the model, and that's to put the information together in this form, in this format of a feedback form. And it's designed to be a visual, concise summary of the information with an approach that's familiar to caregivers by having this spectrum down here of red, yellow, green. And what the practitioner will have generated by the computer scoring are marks of different colors at different points along this called rainbow spectrum. And that way of summarizing seems to work well with our brains, that we have this concise color-coded summary. And what goes into that summary includes the initial interview, the assessment, and then this point here, the video-based coding gets incorporated there. Then the practitioner goes into the feedback session with the parent in this collaborative way I've been talking about, and continuing to use MI strategies to talk together about this summary and hear from the parent. What did they learn from the process? Does this summary that the practitioner is bringing to the table make sense to them? And there's a very much back and forth collaborative conversation to land on a shared understanding of what are the most important strengths of the family and what are the most important struggles, and what goal does the caregiver want to set. Again, going through this parenting lens, what are the goals that the parent wants to set that would then potentially move them over to this part of the process of follow-up services. So now I'm going to talk about the follow-up service of everyday parenting, when the goals the parent sets or parents set relate to improving parenting skills. The everyday parenting curriculum is grounded in behavioral parent skills training. It's not rocket science. It's not going to include stuff unfamiliar probably to all of you. You're all probably pretty familiar with the elements of behavioral parent training that we know from years and years of research and repetition. They really make a difference, these parenting skills. They really help kids' well-being and family well-being. There are 3 categories, 3 modules with sessions within them, focused on positive behavior support, setting healthy limits, and building family relationships. The everyday parenting curriculum is modular with sessions and the schedule tailored to the family. So the frequency of sessions, the avenue or mode of session, it's all going to be tailored to what works for the family. This curriculum includes videos and worksheets to support skill development. One of the pieces I really like are these demonstration videos that can be used with parents that show parents implementing the various skills with their kids. And some of the videos and the role plays that the practitioner does with the family use this wrong way, right way approach, where as part of the engagement and sometimes, having the fun with the parent, the role play or the video will show a wrong way of implementing the skill, followed by the right way. And we find this is a very effective teaching tool. The whole process throughout each of the sessions is based in, again, probably quite familiar to you all, a skills development model that goes through these steps of teaching, modeling, practicing, and debriefing. The everyday parenting sessions that are pulled from this manual, they all go through these various elements in working with the parent to develop the skills that they have identified as their goals. So what we're going to do now is show a video. We'll just watch, I think, 3 or 4 minutes of a video that demonstrates by actors. Again, as we all know, having a real family demonstration video gets pretty complicated and not always a great idea. But these are actors using scripts from real families. And the practitioner here is working with 2 parents on one particular skill out of the everyday parenting curriculum. So we'll start that video now.
So now that we've decided on a few simple rules and consequences, it's time to practice so that we can explain to Lupita what she's expected to do and what will happen when she breaks the rules. Who do you think will explain the rules to Lupita?
I'll do it.
Yeah, he's better at explaining those things.
Okay. So, Senor, since you'll be the one explaining the rules to Lupita, we'll practice with you being yourself, and Senora, you can pretend to be Lupita. Okay? So, before we start, I want to give you this. And some things to remember about explaining the rules is to keep it simple. Just read her the rules and consequences, avoid arguing, and stay calm and relaxed. Okay? Don't lecture her. Do you think she's going to argue with you when you explain her the rules?
Oh, yes, she'll argue.
Okay.
Yeah.
So you might want to start by saying something like, Lupita, I'm going to explain to you a few things, and before I do, while I do, I just want you to sit and listen.
That's a good idea.
Okay. Good. So then, Senor, do you want to start to practice, and I can help you with anything that you're feeling a bit unsure of?
Okay. Okay. So she's going to be Lupita.
Yes,
Okay.
exactly.
Okay. Lupita, I have some things that I need to tell you.
Okay, Papi, what is it?
Well, before I tell you, I need you to just please tell me that you're going to just listen and be quiet. Okay?
Okay, that was good. You stayed calm and you didn't get angry and argue with her. So see if you can finish the explanation.
Okay. So, you know how it's important for Mommy and I that you do well in school and that you do what the adults ask you. Okay?
Yes.
We have talked and we've decided on some rules that are going to help you with that, and we wrote them down so that it can be helpful for you.
But I already have too many rules.
No, you don't. You don't. Please be quiet and listen. These rules, these three rules are the most important rules, and we'll go through them, and I'll tell you the rule and a consequence for breaking each one. Okay? And the first rule is no gang behavior, and what that means is no talking like a gang member, not having friends in gangs, not dressing like a gang person. And the consequence, that's a very important rule, by the way. And the consequence for breaking that is no time with friends at all, okay? Through the computer or through texting or phone for the rest of that day or the next day if this happens at night. The second rule is only go where you say you're going and don't go to places where you don't say that you're not going. We want to know where you are at all times to make sure you're safe. And the consequence for that is, again, no time with friends for the rest of the day, just like the other rule. The third rule is for you to help with housework when you're asked, and no arguing. And the consequence for breaking that rule is 15 minutes of extra work.
What kind of work?
Mom and I will decide, and we will let you know. Okay? But for right now, these are the rules that we've talked about, and Hera and I agreed. Is this clear? Okay.
Great job. Senorita, how did you feel as Lupita?
Well, I felt I could not disagree with the rules.
Good. Good. So when do you think you'll have a chance to talk to Lupita about these rules?
Probably today when we get home.
Today? Okay, and Senorita, is that a good time for you? I ask because even though your husband will be explaining the rules to her, it's important that you're there as well so that she sees that you're in agreement about the rules.
Yes, I can be there.
Okay, great. That was a great segment there. Thanks. All right, so back to the screen, back to the slides. Okay, so now we're gonna talk about the implementation process. Oh, wait, I jumped too quickly. So I just wanted to make a couple points about that video that the practitioner there, I think, really nicely demonstrated the strength, focus, encouragement of the caregivers, and drawing from them in that collaborative, empowering way to ask what was their experience and what's going to work for them and how they're going to present the rules, how they're going to go through this process with their daughter. So those are some things I really like about that example. So now we're going to shift from the content of the model to the implementation process and what's entailed in implementing this model in a community. Starting with the staffing recommendations, I know this is such a critical issue in so many places now where workforce issues are challenging. So we start with these objectives, which is that the goal is to hire staff, train them, to develop the knowledge and the skills needed to implement the model, both with fidelity and with competence. With the staffing processes also tailored to the realities of the available workforce, which I know also varies by community, that there are different levels of qualification available across different communities. Recommendations that we have, there are two roles. There's the provider role, the frontline practitioner, and then a supervisor trainer role with somewhat different recommendations about qualifications for each of the roles. And I also want to talk about a couple logistical pieces here. So for the provider, they don't have to be fully dedicated to this model. And in probably most cases at this point, implementing the FCU model is part of their job, not their entire job, which we find often can work really well, because then the use of the assessment process and then some parenting sessions as appropriate often weaves in nicely with other parts of practitioners' jobs. Moving to qualifications, we recommend that providers have experience with the kinds of behavioral-based parenting interventions and family work that are entailed in the everyday parenting component. We recommend that they be open to evidence-based interventions and responsive to consultation and supervision, which I imagine we want for all roles. While a master's degree is preferred for the direct service provider, it is not required. I just want to clarify that. That's actually been a bit of an evolution with the model as part of this process of being responsive and tailoring to the realities of currently available workforce. Where possible, training or some experience in MI is recommended. The second role is the supervisor trainer role. And here we would recommend more strongly that the supervisor trainer have a master's degree, but again, it is not required. During the initial process of certification, it is recommended that the supervisor trainer have a caseload, as that would be included. The work with the family and review of that work is part of the certification process. And then we do recommend that the supervisor trainer have a supervisory role in the agency. So if implementation is happening in a community, here are the steps of training and preparation that we at Northwest Prevention Science go through with each agency. The first part of implementation includes e-learning. Self-directed e-learning is the first part of training, and that would happen typically across the first month. And the e-learning is followed by webinars, and those webinars cover the two components separately, the family checkup component and then the everyday parenting component. As soon as the family checkup webinars are completed, and there are two of those, implementation can begin. Practitioners can start doing that assessment and goal setting process right away. And that's usually about month 2. And then the everyday parenting webinars happen 3 to 5 weeks later to give the practitioners time to start doing the family checkup before they move into learning about the parenting curriculum. And it's about that same time at month 3 that the supervisor training certification process begins. And then you'll see up here that that's about the same time that a monthly group consultation begins. And that goes for 6 months. And then the supervisor trainer certification occurs over these months and typically is going to be completed somewhere in months 6 to 8. The certification process is pretty extensive. Now to the critical detail that I'm sure many of you are waiting for or wondering about. This summary captures the costs across year 1 and then after year 1. There's an implementation planning process that we engage in with agencies prior to starting the training. And so that's $1,500. E-learning courses, $560 a person, and then webinar trainings. So this is that whole sequence we just looked at: e-learning, webinars, consultation, and certification. And as I said, that certification process is quite extensive and fairly labor intensive. And the goal and the value of the supervisor trainer process, I skipped over that slide on accident. Let me go back to describe that. The goal here is to develop capacity of communities to implement the model independently and to not stay connected to and dependent on the purveyor agency, us, NPS, indefinitely, but to rather develop the skills to get certified internal to the agency to then be able to support ongoing implementation and in the long term to support sustainability of the model. And this process of certification includes a fair amount of video taping and video reviews, first with family sessions, then with supervisor sessions. And the fidelity to the model and the competence of model delivery of those sessions, family and supervision sessions, those are assessed using a tool we call the coach. And I'm going to describe that in a minute. And then the supervisor trainer, the last step is they're also trained to deliver the structured trainings. So I'm going to flip back for a sec. These webinars here, those are the structured trainings that a supervisor trainer is prepared to deliver themselves. So as they hire any new staff, they don't have to come back to us at an MPS, but rather can get staff started on their own by delivering these trainings. And then again, where MPS provides this ongoing consultation for new staff that are trained by us, once a supervisor trainer is certified, they're providing serving the same function with their ongoing supervision. So those pieces get moved to this on-site capability. Now to finish up on this. So that was year 1. These are the costs. And as I said, this process of certification is fairly intensive, hence the higher costs there. After the first year, at that point when there is a certified supervisor trainer who's supporting current staff, any new staff, the program is running hopefully pretty smoothly on its own. We do then have annual half-day CQI check-ins with the agency. And then as new staff come in, they would start with the e-learning courses before finishing their training with the supervisor trainer. There is a fee for access to online resources after year 1. That fee is wrapped into the other fees for year 1, but after year 1, there is an annual fee for access to these online resources, including the web-based questionnaires. And then the supervisor trainers get recertified every 2 years. And so all the costs for each of those steps are listed here as of today. These are the costs as of today. And then I want to just explain a little bit about this coach tool that I just referenced, the empirically validated fidelity assessment tool for the model. And we all love our acronyms. The COACH stands for conceptually accurate, observant and responsive, active in structuring, careful delivery of feedback, hope and motivation building. And hopefully at this point, those concepts all sort of make sense and the pieces fit together for why those would be the elements of fidelity that would be assessed in these reviews of videos with the supervisor trainer. The other way that the coach is used, and part of, if I go back to the supervisor trainer certification, this training in the SCU supervision model involves the supervisor trainer learning how to use the coach themselves with the frontline staff. So first, the coach is used to assess the supervisor trainer to help them develop their competence and fidelity. And then it gets into the parallel process in which the supervisor trainer does the same thing in using this coach assessment tool with recordings that practitioners complete of their work with families. So the process is parallel each step of the way. One quick note, for each of those steps, the supervisor trainer, coach review of their work, and then the frontline practitioner, coach review of their work, the process is that each person self-assesses, and then the person training them assesses. And then the two get together and compare notes and talk about the strengths and struggles reflected in the recording, reflected in the coach. That approach is very much a parallel process to the work with families. The idea is the person who's being trained, either as a supervisor trainer or as a practitioner, that they're engaging in self-reflection, that they're driving the growth and learning process as much as possible. So that's the coach. And this process of using the coach is also connected to assessing what's the level of caregiver engagement. And when a practitioner working with a family effectively implements the model according to all of these dimensions and cultivates strong caregiver engagement, we see that this leads to the best child outcomes. Last point about implementation of the model here is just some bullets to lay out how the model aligns with FFPSA priorities. With these risk and protective factors that, as I talked about before, across the ecological context, we know those intersect and really influence abuse and neglect. And this work to influence parenting protects against social ecological risks that we talked about before and disrupts that cascade of coercive parent-child, caregiver-child interactions and strengthens positive parenting. So same points we talked about very early in this discussion of slides, just circling back to these key elements of the model that intersect with FFPSA priorities. So I am now ready for questions. I think Jess is facilitating, is that right?
So I don't see any questions in the Q&A feature. I also don't see any questions in the chat. So for participants, you're welcome to either drop those questions into the chat, or you can drop them into the Q&A feature. We'll give you a moment to do so. We will give it just one more moment, Lisa, and then we will close it out. I don't see any questions coming through for the in the Q&A feature or in the chat.
So does that mean everything was just absolutely clear?
I do see one question that just came through. The question is, for this model, who provides certified training for it? If an MSW wants to offer this.
Well, thanks for the great presentation comment. I'm sorry, I don't quite understand the question.
For
Jess,
this
did
model,
you
who
understand it?
provides certified training for this?
I think they're asking for clarification on who provides training, certified training for this model.
So we go back, maybe this is a good place to reference. This process is done by Northwest Prevention Science. It's all completed through us as the purveyor organization, including this certification of the supervisor trainer. And then once the supervisor trainer is certified, they on site deliver these webinars and then ongoing supervision and consultation. Did that answer the question?
For the person that asked the question, if there's a follow-up, feel free to drop that into the chat or into the Q&A feature. Great. I don't see any additional questions coming through. And so what we'll do is we will conclude by giving some information about what happens next. So what should you expect next for participants? If you would advance us to the last slide, please. Just as a quick note to those on the line, of course, we want to say thank you so much for joining us. Thank you for taking time out of your day to be here. Thank you to Dr. Ryder for being here with us as well, with the presentation and all the information that you've provided to the participants. There is now a link in the chat. That link in the chat will give you access to your certificate of attendance today after the completion of a brief survey. You take that brief survey, it'll get you your certificate, and our follow-up email with resources, recording information will be available to you in about 2 business days to the email you registered with. And with that, we want to say thank you again, and we hope you have a wonderful weekend.